The COVID-19 pandemic has had a devastating impact on the Alzheimer's and dementia community. Caregivers report ongoing severe stress. And this stress is affecting the care they can give to their loved ones with dementia. Caregivers feel unprepared for what will happen to their family member with Alzheimer's if the caregiver gets sick. People living with Alzheimer's and other dementias are seeing more rapid decline in memory and behavior. Reverend Tracy Lind has frontotemporal dementia. She says often during COVID, her head feels full and her language deteriorates, leaving her feeling out of sorts and emotional.
We walked down the corner to watch the Cleveland Heights graduating class in a car parade, driving down Lee Road in their cars, and everybody honking and cheering the graduates. And I just sat there crying. I'm not emotional like that, but I can't help it anymore. I just kind of keep having to reset over and over again, but every reset gets harder.
In nursing homes, visitation restrictions result in months-long separations of loved ones and their families. Loretta Vini couldn't visit her mother Doris, who has Alzheimer's, for 3 months, the longest they've ever been apart.
My greatest fear was that she would forget me, but the deterioration that I noticed on each backyard visit has really been amazing. They have to bring her outside, of course, so she needs a lot of help to walk, which she never did. Now they have to physically help her out. It's been excruciating. That's the best word I can come up with, and the guilt is just overwhelming.
And tragically, the number of deaths due to Alzheimer's and dementia was more than 20% higher than normal during the summer months. Experts say this is most likely due to increased isolation and stress, poor nursing home care, and COVID-19 itself. As a society, we must do more to protect those living with dementia and their families, including testing and resources for nursing homes so residents with dementia get the best care, and solutions to allow more family visits. We need rapid response support systems for caregivers and more widely available technology to ensure everyone who needs it can access the support. The problem is clear, and the need for solutions is urgent as the COVID-19 pandemic continues.
I dread the coming winter when we all go back inside and have to figure out how to keep each other busy and engaged and challenged and not become totally isolated. That is my fear.
National, state, and community leaders in government, long-term care, caregiver support, and advocacy must seize this opportunity to better prepare for the next crisis. How can our nation build resiliency against future pandemics to protect the dementia community?
Good afternoon, and welcome to what hopes to be an interesting conversation with one of our nation's most prominent governors, Governor Michelle Lujan Grisham of New Mexico. Thank you for joining us today. The demands on you and other governors I know are rather extraordinary at this time during the COVID crisis, and so we deeply appreciate the time that you're spending with us. Governor Grisham is the 32nd governor of the great state of New Mexico, the first Democratic Latina to be elected governor in US history. She's had a very productive couple of years in office, and in 2019, she oversaw one of the most productive years in state history, signing a broad package of bipartisan bills into law, notably a historic investment of public education and a landmark initiative in transition to clean energy. So thank you, Governor Grisham. Just a few introductory remarks, and then we'll get into the questions. The COVID-19 pandemic has taken hundreds of thousands of lives, sickened millions more, and put life on hold for all Americans, with especially harsh consequences for communities of color and for families of dementia. The COVID pandemic has caused an alarming increase in deaths of those experiencing Alzheimer's because, in part, this disease attacks the neurons in the brain as well as the elements of your lungs and your heart and other elements of your body. It has also deprived family caregivers from the ability to use daycare facilities for their loved one, to visit their loved ones in nursing homes and in assisted living facilities, and to bring in daycare help into their homes in order to provide assistance in caring for those that are home. So we've been affected both by increasing the number of deaths in our community, as well as by the impact on the caregiver loved one relationships. You memorably held up a photograph of your mother who lives in an assisted living facility in Albuquerque, imploring New Mexicans to socially distance and mask in order to protect older people who are at high risk. Understandably so, since long-term care facilities across the country have seen a major increase in deaths and a major source of outbreak. But Alzheimer's caregivers with loved ones in long-term care report higher stress because they can't see their loved ones, and importantly, the health of their loved one and help with their care is less accessible than it was before COVID. So my first question is just a little bit about your background and about your experience with Alzheimer's, but how you as governor are beginning to try and balance this need for connectivity of families that are experiencing dementia and at the same time trying to keep them safe.
Well, George, I really appreciate being invited to participate with you all today. And you bet we are all against Alzheimer's and excited about your work and what you do. And I think that you framed it really effectively, which is a pandemic is a national, global crisis of the kind of proportions that we haven't seen in 100 years. And so you have to start with, there's no balancing, it is unfair. You have to recognize that if you don't get it under control, the kind of other consequences, including what we're seeing for both populations on either end of the spectrum. If you're in a long-term care facility, or you're in a correctional environment, or you're a kid who can't go back to school, the social isolation and the inability to support the social and mental well-being of our populations has proven to be an enormous challenge, where you have to weigh, do we risk death by COVID, including to all the other residents and all the other workers, or do we risk having depression and isolation, which has led, I think, to increased mortality rates and related exacerbated underlying conditions. And so we've been a very strict follow the science, and we're a state that has 1/3 less healthcare capacity. And that means that for per capita, we have less than any other state in the nation, and yet we're poorer and sicker as a population than anyone else in the United States. So when I have an outbreak, and we have at nursing homes, there aren't any other caregivers, right? So now we're in a situation like we saw with horror in Spain, where they abandoned nursing homes and went on to other vehicles to provide care and left people to die, which is the most untenable, horrific set of circumstances that we're seeing play out. Quickly, like most states, we're trying to figure it out. Increased testing, rapid testing on site, outdoor visiting, lots of window visiting, notebooks and iPads, and any number of ways to make sure that you're doing video conferencing. And all of that is helpful, but there is nothing that replaces human touch and familial or loved one interaction, including in our safeguards like the Ombudsman program. And we are really struggling here like we are anywhere. And you talked about my mom. I haven't been able to see my mother in person since last December. And she's not doing well. And she's been to the hospital twice. And I couldn't go with her to the hospital. And she keeps getting quarantined. And she can't wear a mask. And she doesn't suffer from Alzheimer's, but she does have dementia. She's got cognitive issues, and she doesn't understand why she's abandoned and where I am. And it is an incredibly devastating situation where I see my mother's health failing before my eyes because I can't get in there. And right before this conference, her physician called me to say she's not doing well again today. and we're going to try to wrap around in some way. The answer to this issue is threefold. One, we have to have better preventative strategies. We need fewer people in long-term care facilities. We need better strategies with backup for a pandemic for families who find themselves also without access to critical care. And three, as a country, we need to do much better at public health and infection control, because the countries who got it under control aren't having these debates about social isolation for their vulnerable populations. We are. As Americans, I've crushed this virus in New Mexico twice, and now I have to do it again because there's a resurgence. So people won't wear masks, they won't socially distance, they won't protect those caregivers, and that is a problem. And this is a country that needs public health and public health prevention education. I'm going to tell you early childhood education all the way through the end of your education, because we clearly don't understand how to manage it. And that really, in fact, is the answer.
Well, I think there's no question that you're absolutely right. We speak of the populations that have pre-existing conditions, which are more vulnerable, who are more vulnerable to pandemics, this one, but also to other pandemics. If in fact we could strengthen ourselves by improving our health of pre-existing conditions, namely chronic conditions, we'd be much stronger as a community in resisting pandemics. So you're absolutely right. But what is interesting and what's challenging about this is that the pre-existing condition set, the chronic condition set, it disparately affects communities of color and low-income populations, which means that our strategies have to be directed in particular, not solely, but particular about improving public health conditions, chronic conditions in low-income and communities of color. So I'm curious as to whether you view it that way, and if that's so, what you might be doing as governor to try and mitigate these disparities that we're seeing in pre-existing conditions, chronic conditions, and hence vulnerability.
I totally agree with you. I mean, this is one of the reasons why I'll digress. I promise not, and be not as long-winded.
Oh, go ahead.
I like you. In this state, a rural frontier state, one of the poorest states in the nation, using old, antiquated, unfortunately, I can't change Medicare calculations. We don't have the resources here to build the kind of healthcare system. Not that the country does it very well, but we are in far worse shape. And yet we haven't overrun our hospitals, even though we're surging. We've done very well with our healthcare clinics. There's no out-of-pocket costs for testing or for COVID-related illnesses. Our insurance costs are coming down, our premiums on the exchange, and we have 43+% of our population on Medicaid, with the most robust set of Medicaid investments and benefits, frankly, I still think, of any other state in the country. And we are building that out all of the time, looking at public options and other ways to really build an effective healthcare system that is based on prevention on the front end. So if we weren't doing COVID well, and there was a New York Times article on, and we're surging right now. So if you're watching CNN, you can see that we're struggling to keep the infection at bay. But our mortality rate, given that we're a minority majority state with the largest individual numbers of sovereign nations, pueblos and tribes in the country, our mortality rate should have been much higher. Why wasn't it? Well, we did a lot of containment and a lot of good public health strategies on the front end, but we also know that if we don't get it right, it would be much higher. 1 in 3 adults in New Mexico suffers from high blood pressure, heart disease, kidney disease, the most serious of those chronic consequences that make us more vulnerable to, say, H1N1, so those flus, and to this particular virus. It is clear that we aren't doing the right preventative work, and Medicare is shifting in that direction. Medicaid has to catch up, and we must fight to make sure that we're teaching and treating social determinants of health by population health in this country. And until we do, we're going to spend far more on the back end which means we aren't going to be dealing with preventing Alzheimer's and dementia and applying curative measures, which I think are now in the pipeline. You know, this is a country that keeps catching up, and we never had to be in this position to start with. And you are right, George. My mother's dementia is completely related to all of her other underlying conditions and bad public health choices on her part, including smoking.
Well, as you know, we're in the brain health business, so to speak, so singing the same song you are. But as we think about how to build out greater capacity in the health system to be able to understand, detect and understand how to treat brain health issues, at least neurological conditions in older populations, although we're beginning to work with the mental health community on younger populations. One of the critical things is how to build out a healthcare system that's better prepared for brain health issues of aging populations. And so one of the strategies that we are considering is how to build greater capacity, both in terms of resource and in terms of expertise and tools and tests into the community healthcare system. So I'm curious as to what the quality and nature of your community healthcare system in New Mexico, and whether that is a strategy which deals with a capillary of the general healthcare system, which is more attuned to low income and people of color populations.
New Mexico has a lot more to do, but we do actually have I think, a very effective community health and more holistic healthcare system, because we've had to do that given the rural and frontier nature. You know, we've got some communities that have very limited access to practitioners. So if we don't use an integrated private and community healthcare model, we have one of the most successful telemedicine, telehealth models in the country that has been now the focus of considerable both international and federal investments. And they are looking at Alzheimer's and related issues so that primary care practitioners, who often are internists and geriatricians, get even more support and more education and training to think about ways to detect it early, diagnose it early, and to do the kind of preventative investments and work that families really need in order to both prepare and prevent to the highest degree that you can. And I feel really good about those efforts and investments, but none of it's enough. Although I might just point out that in my first legislative session, we invested in centers of excellence. Our bioscience center of excellence is in our one of our universities that's got our medical school, which is an incredible medical school given the size and nature of the state. It's fantastic. And you know, UNM, the University of New Mexico, is being credited as one of those research institutions that's in the market for doing the research to cure Alzheimer's, and is listed as one of those institutions that's in that race to productively get that over the finish line. And it's really exciting work. And I think states who suffer from more chronic conditions, more dementia, more cognitive impairments, more Alzheimer's need to be in that leadership role, because we can solve any number of these issues all across the country and all across the world. And something, George, I didn't say, Alzheimer's dementia is the cruelest disease. And it doesn't care who you are or where you are, how healthy you've been, although we know that there are exacerbating and pre-existing situations and conditions that create other problems and risks. But when you add that to COVID, I just want to make sure that everybody's hearing our conversation. This has been a very painful dynamic for everyone. And it is the kind of thing that keeps me up at night. And I'm looking at newer strategies in addition to prevention and cures and treatments that would create cooperatives so that caregivers who make the lowest can own their own assisted livings and be in an environment or have collaborations with families so that we create a pipeline and wealth and equity for the men and women who are largely Hispanic in this country, or minority populations who are providing support to familial caregivers. And I know I'm preaching to the choir, you know, more than $500 billion worth of care. And while my mom's on Medicaid, and thank God for that, and Medicare, and gets help from any number of programs, without my involvement, I assure you, she would cost the healthcare system more. She would not have lived this long, and she would not have any quality of life despite the loving attention people try to provide. It's not the same. I do it better. I'm more effective, and her doctor will tell you I'm better at diagnosing what's going on with her because I don't have to figure out her baseline. I know her.
Yeah. Well, as a member, the reason I started this organization 10 years ago is because 3 generations of my family have been impacted by Alzheimer's over a 40-year period. And I thought that if, in fact, we didn't accelerate efforts and adopt new strategies and get more resources, 40 years from now, if the situation were the same, it's my kids and my grandkids. Of course, men are always in denial, but it would be my kids and my grandkids.
Doesn't seem like you are, George. You're awesome. And I know we're running out of time, but I also want to pitch Medicaid, Medicare, healthcare financing, making sure we don't miss an opportunity to deal with this.
Absolutely.
Alzheimer's, if we don't.
My organization will be seeking more resource for community health centers and strategies in leading areas to try and use community health centers to really try and get at both the prevention elements of this, as we're seeking a national prevention strategy, as well as improvements across the nation. So we will be back in touch, Governor Lujan.
Good, and let's expand CareCorps, which is a kind of a national Peace Corps replication strategy aimed at having more volunteers trained and supported, never to replace paid caregivers, right? You know, our men and women who dedicate their lives to making a difference, but it is a way to support families and the individuals who are suffering and are losing independence and want us to treat them with dignity and respect. So I'm excited about that. Maybe we can work together on more funding and more support for that. And so let's do 3 things. Let's attack this pandemic and solve it. Let's take care of our families and their loved ones who are in long-term care and at home. Let's cure Alzheimer's. Let's prevent Alzheimer's and chronic conditions. And let's create an environment where Americans are the healthiest of all populations in the world. And let's focus on a group that really needs us, that will also, frankly, save the country. If we're worried about the federal deficit and the national debt, look no further than making sure we do something about our long-term care expenditures.
Well, the only other thing I would say together is let's all vote. Let's all vote. Let's get an administration one way or the other. I'm not going to take a partisan view here, but one way or another that will actually take exactly your 3 priorities and go execute on. Thank you so much for your time, your insight, your comment, your energy. And I love your vision, and we will be partners in the future. I am confident. So thank you for joining us.
Thank you.
All right, take care. Now we're going to turn to our panel discussion on COVID-19's effects on our community and what can be done about it. This panel is going to be moderated by Meryl Comer. Meryl Comer is one of my co-founders of Us Against Alzheimer's, New York Times bestselling author, a fierce advocate after years of caring for both her mother and her husband for 22 years at home, her mother for 10 to 12 years at home. So she's had a long journey with this disease, knows exactly the experience of being a caregiver for 2 loved ones at home. And I thank her for her friendship. She's been a friend for 20 years in this fight, but a friend socially as well. But we are partners in this battle. And we thank you for your loving care of your husband and your mother, for all of your work on behalf of patients and caregivers. And thank you for being such a great partner and a great friend of mine.
Thank you, George. The theme that has run through the summit is the disproportionate alarming side effects of the COVID-19 pandemic across the Alzheimer's and dementia communities, including, as you've just heard from Governor Lujan Grisham, the personal heartache of those with loved ones living in long-term care facilities. The stats in the earlier opening video are from the latest longitudinal A-List COVID survey series that has been taking the pulse of the patient and caregiver community over the past 7 months. And for those A-listers joining us today, we're over 8,500 strong. We hear you loud and clear on what matters most, and we hope you'll see in this session what matters most to you, how your issues drive our advocacy. Joining us now is our esteemed panel, Dr. Kenneth Davis, President and CEO of the Mount Sinai Health System in New York City. It's one of the nation's largest integrated health systems, which includes the Icahn School of Medicine at Mount Sinai, 8 hospitals, and over 300 ambulatory sites. Dr. Davis is a neurobiologist and one of the most highly cited researchers in the field of brain medicine. Welcome. Also joining us, Terry Fulmer, PhD. She is the president of the John Hartford Foundation, world renowned for its philanthropy devoted to the health of older adults. She is one of the leading experts in geriatrics and best known for the National Niche Program, her research on the topic of elder abuse and neglect, and her recent Age-Friendly Health Systems Initiative. Our third panelist is Edwin Walker, Deputy Assistant Secretary for Aging of the Administration on Aging within the Administration for Community Living. I'm going to come back to you on that. A lawyer by training, Mr. Walker serves as the Chief Career Official for the federal agency responsible for advocating on behalf of older Americans. Thank you all for joining us. Dr. Davis, you're operating on ground zero. We're into the middle of a second surge in the pandemic, double whammy projected with the flu. Give us an update.
Well, right now, it's not nearly as bad as what it was in the spring. When we were at our peak level in the spring, our hospitals had over 2,000 COVID patients. At our low point, which was about a month ago, our hospitals had 17 COVID patients. Today, we have about 110. So had this been the initial pandemic with 110 patients, we'd be celebrating. This is so far not a second wave, at least to the degree that we have feared. It's a very manageable number, and we've learned a whole lot more about how to manage this disease.
On that very point, what systemic issues did the COVID crisis expose in the health systems, and are we any better prepared for the next round?
Well, let me give you a little story around that, and I think it'll give you a sense of were we prepared and did we know what we were doing at the beginning. Our system, our hospital system, is fortunate that we have a number of affiliated hospitals in China and medical schools. And as a consequence, when Wuhan happened, we began to talk to our colleagues there and began to appreciate what could happen in this country. So before the epidemic hit, we were purchasing protective personal gear in China, and it was loading onto planes well before anything happened. Our Chinese colleagues had no more idea of how we would treat this disease than we did once it came. And we really had no idea the kind of numbers we'd see. About the second week in March, a few of us who run large hospitals in New York received a call from our governor, Andrew Cuomo. And Governor Cuomo said his epidemiological models suggested that we would need to double the number of beds we had in our hospital system. We were amazed and frightened, but immediately began to do everything we could to prepare. Ultimately, we only had to increase our bed capacity by 50%, but still that was a lot of beds. Doubled up everything in the ICU, put beds in atrium, opened a tent in Central Park. We had to do a lot. And along the way, we learned. We didn't know when to intubate patients at first. We were probably doing too much. We didn't know when to give remdesivir. We knew that there was an immune response, but we didn't know early on where to give the steroids. We knew that antibody treatment might be useful. We didn't know exactly when, and we had to create from convalescent plasma antibodies. When we looked at autopsies, we found out that we were seeing little thrombi, little emboli in lots of organs. And we realized that we, at some point, needed anticoagulation therapy. Ultimately, then, over the next couple of months, we learned how to take care of patients. And now we're far better. And the death rate from those people who come into our hospital is a lot lower.
Thank you. Dr. Fulmer, you're a geriatric nurse practitioner, multiple nursing degrees. What are the sentiments in the nursing profession about the pandemic and the conditions in which they've had to operate?
Thanks, Meryl. And like every discipline, all of us have needed to practice in a very different way. And we've needed to think creatively as part of the healthcare team to make sure that we've been as effective as possible. And thinking about nursing, that's a big tent, Meryl. There's like 3.5 million nurses in the United States and another 4 million certified nurse assistants and home attendants. So where we practice has had a lot to do with how we feel about the way we move through the pandemic. Let me give you an example. A friend of mine who works in an intensive care unit in this country was really overwhelmed with how quickly supplies came to her in that moment, with masks, gowns, gloves, all the PPE that we've talked about, and the way in which staff were shifted from one unit to another to go help in those circumstances that were so dramatic. Now, if you're a nurse in a nursing home, you had a very different experience, because nursing homes were really an afterthought in this pandemic as we started. That's not the case today, but as we started, all equipment, supplies went to our acute care facilities. And as we've learned, that could have had a great deal of negative impact on individuals in the home setting, in the nursing home setting. So that's why you'll hear me talk about some of the approaches to change that for the future. But I think that your experience is going to be also rooted in whether you were in urban or rural, whether you were in a hospital that has means to cope versus not. So we've seen a lot of different experiences around the country and around regions.
Mr. Walker, your agency has a unique and challenging mandate, even in the best of times or normal times. What does it do, and how did your agency adjust to meet the enormous increased need when COVID struck?
Thank you, Meryl, and it's my pleasure to be here today. As you mentioned, our agency, the Administration for Community Living, Administration on Aging, has the responsibility to implement the Older Americans Act, which was created in 1965 and created a national infrastructure of health and human service agencies that consists of dedicated individuals at the national, state, and local levels. And they give of themselves. They are people who are truly, when I say dedicated, they go well beyond the call of duty. They believe in the mission of caring for older people to enhance their independence, their dignity, but also to enhance their optimal health. And so because of COVID, we found that they became very innovative, very creative. They were very adaptable. They adapted to the changing situation, and they responded to the needs at the local level. That's one of the things that they're supposed to do on an ongoing basis. Our funding is flexible enough to be responsive to local needs. And I, as an individual in this network, am so proud to be a part of this incredible network.
But what were the systemic issues that were uncovered? Because that is one of the byproducts of COVID, looking at systems that aren't working.
Well, we didn't have therapeutics. When you look at what is the incentives for the pharmaceutical industry, incentives for the pharmaceutical industry are to develop drugs for chronic disease, drugs that you can take all the time. No one has focused on coronavirus and developing treatments for that, because an acute treatment is a short-term duration of administration. But I think what we've really learned the most is what we've known for some time, but it was emphasized here, and that is that underserved populations, minority populations, have a disproportionate share of disease. And that's because we continue to not address the social determinants of healthcare. And we have to rise to the occasion and realize that the most unfortunate members of our population really need our care, and we have to invest there. Otherwise, they will always have the worst outcomes.
Dr. Fulmer, you've been quoted as saying the greatest success story of the 20th century has been the increase in longevity. However, we haven't addressed how to take care of those who make it into old age. Now, in what way did COVID expose this type of neglect?
Sure.
Is that a good term, neglect?
It is a good term, Meryl. And I do say that we love longevity. We love to say our grandmother is 98 years old, but we don't like to take care of people. And we've seen that in the way in which we have distributed resources, in the way in which we have supported workforce, in the way that we continue to hear ageist comments throughout this pandemic. We heard people say things like culling the herd. I must tell you, how horrible is that? To hear phrases of that nature. And so I think that, for our foundation, since 2015, we have been doubled down on creating age-friendly health systems. And an age-friendly health system starts at your kitchen table, might take you through the emergency room to the ICU, back to your home, but it's a system where there's information that crosses care boundaries, and people use a shared language, and they understand fundamentally what's going on with the older adult. And we've seen a failure of that. And so it's something that we're working hard on. And also we've seen a gutting of the public health system over the past couple of decades, to the point where, all of a sudden everybody's saying, wow, we really need health. The governor said it, we need health promotion, disease prevention. So we're also working with Trust for America's Health in Washington, D.C. on creating age-friendly public health systems and that shared narrative, so that if somebody were to go home in a public health office in your neighborhood, knew it, couldn't we do better than what we've been doing? Julia Adler-Milstein is an esteemed researcher at UCSF, and we worked with her to learn how we were doing in terms of post-acute discharge information transfer, and the data were very disheartening, in that people can still show up to a nursing home or home care, and it might take 2 more days to find out what medications they're on, what their allergies were, and who's supposed to show up. So we can do better than that, and I think that everybody is very focused.
I think we'll be getting back to that topic. Mr. Walker, as of July of this year, the rate for dementia and Alzheimer's fatalities was nearly 20% higher than the average in recent years. And there has been a disproportionate impact on communities of color that has even extended into the essential service workers. What are the systemic disparities that you wrestle with on a day-to-day basis?
Well, one of the things that we are charged to do is to serve those in greatest need. And specifically with regard to the grants that we give out to states and local communities related to Alzheimer's disease and assisting caregivers, we focus on those that are historically underserved, or those that are communities that are ethnically diverse. And so that's how we attempt to address those issues with the population you identified.
Dr. Davis, let's be quite direct. The experience of many families with a loved one with dementia in a hospital is not a positive one. Hospitals never seem to have been equipped or designed to manage dementia patients with comorbidities that need that direct care. Can you address what happens in normal times and what happened in this time, and how it compounds your effort to care for people?
Well, what happened in this time was incredible, because we had to bring in staff from every discipline, orthopedic surgeons who wound up as transporters. So the last thing we had was the ability to put somebody at the bedside of a demented patient with COVID and give them the kind of care that they might have demanded. In normal times, it's difficult, but not impossible. I mean, we try our best to add staff in those cases. We are a healthcare system that is particularly sensitive to dementia, being one of the first Alzheimer's disease research centers. We recognize that those people need more care. But you have to remember that at the end of the day, what we are reimbursed for the average Alzheimer's patient is determined by Medicare. And in many environments, Medicare relatively underfunds the cost of care, so that every patient who walks into your hospital, you're losing money on. And in that circumstance, when margins are that narrow, it's very hard to do what maybe really you'd wish you could do.
There's another term that comes up, and that's granny dumping, where senior citizens end up in the emergency room because families can't manage them. Terry, do you want to comment on that as an issue?
Yeah. That's been a phenomena that's been observed since the 70s, Meryl. And there was one particular episode that ended up on the front page of the New York Times, and it was an older man with Alzheimer's who was left at a dog track in Minnesota with a T-shirt on that said "Proud to be American." His family dumped him there, and they were caught. They were persecuted. They were prosecuted. But what we know during these times is that caregivers are stressed out of their minds. They don't have resources. They do imagine that the emergency room will give them some relief. Having served as an emergency room nurse, I understand that. What I would say is that how do we get to a point where people's only refuge is an emergency room? That's a societal issue. And I think Ken pointed that out already. Like, what are we valuing? Do we know are we supporting our family caregivers? Are we aware of who in the community is going to be most at risk? Are we working with our adult protective service colleagues in order to really identify and preempt and predict and make sure this doesn't happen? When I worked at Yale, we did a study of emergency rooms and we screened for elder abuse and neglect. And it turns out that far more people were neglected than actually physically assaulted or abused. But for those individuals who were neglected, they were much more likely to die, because if you don't feed somebody, if you don't give somebody water, there's going to be really serious consequences. So I think that it's societally, we need to shore up adult protective services, make them a part of the care conversation, work with ACL in all the ways that they are in the communities with the AAAs.
Mr. Walker, the statistic that always confounds me, and as a longtime caregiver, 50% of social services never get used by caregivers because they can't get out to use them. Now, do you find that in your advocacy on behalf of older Americans that many times we don't take or participate in programs because we don't know they exist, or there's still a stigma about needing to ask for help?
Both. Both is the answer. Certainly, we've often said that we're the best kept secret, one that we don't want to keep as a secret, and we wish that others did know about us. I think our message would be that we are here. Our mission is to care for other people, older people themselves, but also the caregivers of individuals who need that type of assistance. And we are seeking we're seeking you out. We're looking for you. We do have a 1-800 call line. It's called the Elder Care Locator. You can go on the web and anyone can access help in their local community. It's great. But as it relates specifically to caregivers, we are aware that most caregivers don't even think of themselves as a caregiver. And we believe that the first step is to first acknowledge that you are a caregiver. Second is to know that we're here. Third is to then ask for help. It really is okay to ask for help. That's what we are here for, and that's what we're desiring to do.
Thank you. I'd like to go back to the A-list survey, because 75% of those taking care of people with Alzheimer's disease at home were so anxious about what would happen to their loved one, Terry, if the caregiver got sick. And that is similar and averages across the board. Now, we are talking about an unpaid labor force of over 16 million caregivers providing 18.6 billion hours of care last year, a contribution to the nation of 244 billion. Does the government have a plan B if we get sick?
So a government question would probably be Edwin, but I would just say that you're underscoring the need for respite and peer support and programs that really get in there and shore up all the different supports that are so desperately needed. And I do know that through the ACL, there is federal programs that are being expanded, but let's let Edwin talk about that.
Thank you, Terry and Meryl, for the question, actually. And we have what's the National Family Caregiver Support Program. It was created in the year 2000, but we also have the Lifespan Respite Care Program designed to address the very issue you have. Most recently, Congress passed 2 pieces of legislation focused on RAISE, which focuses on caregivers and the supporting grandparents raising grandchildren. And Terry's foundation has been wonderful in supporting the RAISE Family Caregiver Advisory Council and helping us get information out, building a strategic plan for this country that we will then give to the Congress as a roadmap of where we need to go. We have been holding meetings, hearing from these experts from around the country in terms of caregiving, giving us ideas of what we need to do. We've also looked internationally at what other countries have done with regard to caregiving. We're always looking for the best solutions, and we intend to roll those out in this country so that we can provide the compassionate care that we know people need and that they deserve.
Dr. Davis, I'd like to come back to you because it seems quite obvious that we haven't begun to understand the collateral damage from COVID. What are your concerns about what we call the long-term chronic effects of the pandemic, from brain fog?
I'm very concerned. At least a third of patients who get admitted to our hospital and a higher number who get admitted to the ICU wind up with a chronic condition that can affect brain, kidney, liver, lungs, or heart. So this is a chronic condition now. And what we call brain fog is really troubling for those of us who really have been a part of the Alzheimer's community. What we don't know is, are we increasing the risk for Alzheimer's here? Are we speeding up the time at which people will have their first significant symptoms? Since we know that Alzheimer's changes start 25 years before people have symptoms, we can assume that the kind of changes that COVID is causing is only going to make that happen sooner. So it has to be a real concern. It has to be something that we study and something that we may think about how we can prevent.
Terry, do you want to pick that up as a long-term chronic issue to manage?
Sure.
It's all management now.
It really is. And when that goes back to workforce. And so we have to make sure that we have a workforce that's prepared, can understand the symptoms, and can be carrying out the different modalities that are so important. Let me give you an example of what I'm thinking about, Meryl, and that is during the pandemic, we saw, as you pointed out, people who were isolated in their rooms, in their homes, in their communities. And so what happened? People began to have mobility issues, maybe some delirium, maybe some true changes in cognition that were missed. Their medications may have gone unfilled. And so you're hearing me talk about the 4 M's of an age-friendly health system, where every single person in the care system, whether it's a home attendant or a surgeon, can figure out how to use our 4M set of what matters to the older person and their family, is what's most important to them, really at the center of the care plan, and let's hope it is. And we know that that is so essential. Mobility, look at how people have had stories where they haven't been out of their rooms for days at a time, and there's muscle wasting, sarcopenia, as we call it in the healthcare business, but muscle wasting that will take a long time to bring back. I mentioned medications where they may not be filled, or people might be taking their medications incorrectly and not knowing it. And then the whole notion of mentation, your mood and memory. So if that's changing, so if we could all just think about that simple set, that's what caregivers across the country and around the world need to be thinking about. We need to distill it, and we also need to teach the public to demand attention to those elements of care so that they can get the care plan that works for them.
Let me just follow up with that for both Mr. Walker and Terry. The social relationships as predictors of health. Have we moved in that direction? There was a recent intergenerational study by AgeWave in the Edward Jones Retirement Survey, and it reported, of course, loneliness is pervasive across generations, but as people age and that physical isolation, it becomes an even greater health risk and is linked to increased risk for heart disease and dementia.
So Meryl, yes, the AgeWave study, but also the National Academies of Science, Engineering, and Medicine almost presciently released a study on social isolation and loneliness in February. Imagine that. And so what they showed is that the subjective sense of being isolated and the objective sense of, excuse me, I got that backwards, the objective sense of being isolated, the subjective sense of loneliness has been compared to smoking. Isn't that something that it can be that detrimental? So I would recommend that anybody take a look at that. There are recommendations in that study from the National Academies to say what we need to do about it, but make no mistake, it's very detrimental to health.
You know, when you look at these various surveys, Americans 65 and older fear Alzheimer's more than COVID. So Dr. Davis, you've conducted pioneering research that led the FDA to approve 4 of actually the first 5 drugs for the symptomatic treatment of Alzheimer's disease. What does this pandemic portend for the future of research and aging populations? Because as a society, we are headed right into the slow boil pandemic, that's a George term, of Alzheimer's disease.
Well, hopefully the increased risk that was associated with aging is going to be something that will be intensively studied, that there will be more dollars to the NIH to ask, what are the vulnerabilities of elderly people? What makes this happen? And can we do something to strengthen those barriers that can protect the elderly brain from some of the insults that are a part of our environment?
The notion of brain health and what we can do, you're one of the top researchers. My husband maintained his brain and it just didn't matter.
Yeah. Well, if you have bad genes, there's not a lot you can do. However, we do know that if you decrease your cardiovascular risk factors and you exercise, it's the best way to delay what could be the inevitability. So if it's a 25-year process from the time the plaques and tangles begin to develop in your brain until you have symptoms, the goal here is to make it a 50-year process. And there are things we can do right now that we know that can slow that down. As I said, good cardiovascular health, decreasing all those risk factors that are associated with cardiac disease, keeping a normal blood pressure, normal lipids, and getting regular exercise. Those things are going to slow the ultimate progression. And hopefully we'll find a drug that can do something as well. But right now, what I tell people is just whatever you're doing to protect your heart, it's going to protect your brain, and make sure you exercise.
I don't know whether it alarms you, it alarms me that the baby boom generation has already begun to reach age 65 and beyond. So that's the sweet spot in terms of risk for Alzheimer's disease. And now the oldest member for the baby boomers turned 74 this year. So we can see this wave coming, Edwin. Is your agency prepared for this coming wave of boomers? There are 58 million in the country right now that are 65 and older.
Well, while we are the Administration on Aging and we focus on those who are already there, we really focus on all ages. We believe that it is never too late and that everyone should plan effectively for their longevity. Everyone loves the idea of living a long life, but they want a good quality long life. Science has proven what contributes to living a good quality long life. And it's just like he said, we have a two-part strategy as it relates to Alzheimer's disease and dementia. The cure strategy at NIH, NIA, and the care strategy, where we're focusing on those who are struggling with the disease now and those who are caring for them, and teaching them evidence-based and evidence-informed interventions and tactics that will help make that care journey easier and tolerable. And so we just are really focused on both strategies and addressing all populations during this time. It's the only way to go.
I'm talking to a group of panelists who really collaborate and have a similar mindset. And I want to go back to something you said, Ken, about the Medicare fee for payments. And you've all been leaders in trying to move away from fee for service medicine to sort of value-based population health, with the aim of keeping more people healthy and out of the hospitals. So tell me what that looks like, and where does it sit based on where we are right now?
Well, we hoped that it would have come sooner. We were all very enthused at the notion of pay us to keep people well. Give us a per capita rate for a group of patients, and we get that amount of money no matter what happens. So instead of being rewarded when people get sick, we're rewarded for keeping people well. It's been slow in coming for various reasons. We hope it'll happen sooner, but ultimately it has to happen because employers, employees, federal government, state government, nobody can afford healthcare. If we don't change the economics of healthcare, we're going to have just an even worse problem 5 and 10 years from now. So let's hope that population health and value begins to catch on in a larger way.
Terry, do you want to add to that?
Yeah, I'm thinking about the word hope, and I'm thinking that we need strategy, and everybody would agree with that. Two groups come to mind that I also want to just call out in this conversation, and one is AARP and everything that Sarah Locke is doing as they lead the Global Brain Health Initiative, and the number of resources that are available and to the public in that work, and also to advance what needs to happen in society. Certainly the National Institute on Aging, with its $3 billion annual budget, maybe it'll be higher next year, is making great inroads in thinking about not only the science of curing Alzheimer's and related dementias, which is so important, but also the caregiving strategies. And I know that Richard and his team are really working hard on that. The other group I want to point out is the Milken Institute for Aging under the leadership of Nora Super, where she also has a brain health initiative. And all of these come together to be a more powerful force to make sure that the public knows what these strategies are, what we should ask Congress for, what we should be asking a next administration, what are the different features that we would like our state government to be really focused on. So those are some of the things we have to do now.
I think as advocacy groups, we have our Be Brain Powerful campaign by the Women Against Alzheimer's, and we are really following the research because it needs a different conversation. This is a conversation about empowerment and what you can do to stay healthy as you age. So I think it's really critical. We have a question from our audience, Dr. Davis. And again, it's obviously a concern for someone with a loved one who has probably had the disease. Can you discuss any special protocols that are taken for COVID patients with dementia? Many are scared, confused, especially with all that protective gear that providers have to wear.
The protocols, whether you have dementia or whether you don't have dementia, are the same. It's the convalescent plasma, antibody treatment, remdesivir, dexamethasone, anticoagulants, they're appropriate. It doesn't matter. Everyone's treated the same way at this juncture. We have no reason to suspect that it should be any different. The longer term question is, so once those patients recover from COVID, but have the added burden perhaps of mental fog on top of their Alzheimer's disease, what do we do then? And We don't know the answer to that question. We're just going to continue to give the Alzheimer's drugs and hope that that mental fog diminishes.
Can you describe what brain fog is like?
It's totally different in almost everybody. And the reason for that is because this disease doesn't just affect the memory part of the brain, the part that encodes new information. This disease can affect lots of parts of the brain. So whether it's a concentration problem, an attention problem, a word finding problem, a long-term memory problem, a coordination problem, it all depends on what part of the brain got inflamed or what part of the brain wound up with tiny little.
Let's look at what COVID has done, Mr. Walker, to our lives. We're here virtually. We would have been in person before. What do you see as the promise for telehealth? It was discussed earlier in our summit, but relating to dementia-related aging. And I only ask that because it's assumptive that the communities you serve have access to the virtual services.
Yes, what we've seen is an expansion in terms of telehealth and acknowledgement that telehealth is a key component, and that we're very pleased that Medicare is now paying for telehealth visits of all types. We are pleased that of the responsiveness. We've seen how important that really is, but we've also seen, and this relates to rural areas as well, in particular, where virtual programming is just necessary during this time. We're pleased that our entire aging services network and all the programs that we've operated, many which have to date been very hands-on, direct contact programs and services, we've found ways to do them virtually, ways we would have never even dreamed of before. And that means the ability to reach into remote areas, frontier areas. Now, there's a challenge there too, because we acknowledge that we've had broadband issues, which it looks like I may be having right now, but broadband and internet issues. But we've worked with the FCC to make internet tools, cell phones available, and to broaden the concept of broadband throughout the country. But we're just excited and pleased about how much telehealth has been broadened at a time when we need it most. And we think it will set the stage for the future. Many of the things that we're doing now virtually, we think that we will continue to do that. I've heard that universally from every component of our aging services network, that it's making them rethink their entire operations and that they will be effective in providing services in a remote way. For caregivers, it will be even more convenient because in-person programming that they used to have to carry or take an individual to, now they will be able to receive those services in their home, remotely, on their own timetable. And so we see this as a win-win all the way around.
Dr. Fulmer, predictions are that there will be a workforce shortage of caregivers. We've discussed telehealth, but what is your view of apps and avatars and robots? At first I laughed and was offended, but who knows in this world?
Yeah, thanks, Meryl. And I mean, I'm a very big proponent of all the different technologic solutions that we can bring to bear on caregiving for older adults and on solutions for older adults. Let's face it, it's a lot more humane, going to Edwin's point. It's much more humane, whether you're in Manhattan or whether you're upstate New York, where I am right now, to have a person do remote telehealth. Here's a story that was so poignant to me. I was working as a geriatric nurse practitioner, and that afternoon we had set up a clinic, a GYN clinic for older women, and I do mean geriatric women. And they came to the hospital, and they came in ambulance. This was an urban setting. And we got all these frail, disabled older people up to the clinic. And in fact, that day, there had not been a delivery of the equipment needed to give them care. So they all had to go home. Never was I so, my heart broke for these people who had struggled to get there. So fast forward, I'm upstate New York. I am a member of the Bassett Medical Center Board. Our health system covers 6,000 square miles upstate New York. And all it has to do is snow one day and everybody's healthcare is completely dismantled. Well, now we have a new day. And so I just add two other groups. The American Telehealth Association is a very powerful resource to all of us as they use their capacity in Washington to make permanent changes to telehealth and telecare. And the other group I want to comment on very briefly is the MIT Age Lab, where Joe Coughlin has really done a lot of exciting work on ways in which we can use self-driving cars, and even the simple little things like the robotic cats and dogs. We had an earlier conversation about pets, but these robotic and dogs are shown to decrease anxiety in older adults who have memory problems or dementia, and they're shown to be very effective. So we have to use every strategy that we can. A lot of people are keen on sensors, and I think that it's going to be also very important to pay attention to the older adults' preferences. How would they have felt if they had a sensor on them or a camera on them? If you were going to use substituted judgment, is that something they would have been okay with or not? We've got all that in front of us.
We only have about 8 minutes left. And Dr. Davis, I really would like to move on to the vaccines. I mean, there are 170 candidate vaccines being tracked by the World Health Organization. Experts say that they'll be available for vulnerable populations. Our A-list seems more interested in getting them the vaccines for their loved ones. What is the conversation that doctors and nurses have with families, with loved ones, with advancing dementia on whether to have a vaccine or not treat?
So these are tough questions. We hope that within a month or two, there'll be approval of either the Moderna vaccine or the Pfizer vaccine. What we don't know is how efficacious they will be, particularly in older people. So we have to get a hard look at what the efficacy is before we make a recommendation. Remember, these vaccines have to decrease the frequency of COVID infection by some 60% over placebo to be approved, at least by the regulations that we've so far said. But that's over a large population. What does that mean for people over 65 or 70 or 80? We're really going to have to dig down and find out and make a decision about whether it's really worth it. If hopefully the safety of these vaccines will be real, and we won't have to worry about that side of the equation, but we'll only have to worry about efficacy. Our group is meeting almost as we speak now to develop protocols for how will we deliver this, where will we deliver it, who will we deliver it to. We're getting some guidance from our state, which is listening to what we've heard from the feds, and clearly we're going to be targeting at-risk populations and healthcare workers, frontline workers. And that will be the first round. So who are the high-risk populations? Elderly people, particularly elderly people with comorbidities. So we can anticipate that those will be the first line to get what drug, what vaccine will be available.
Thank you. We're out of time, but my final question is something that George actually asked of the governor. If you could orchestrate one or two changes to ensure we're better protecting families facing this looming Alzheimer's epidemic, what would it be? Did I stump my panel? What?
Meryl, I can start and say that families need to know that they have a healthcare system and a public health system that will be there for them. They need to, there's been some confusing messaging. They need clear messages, clear communication, and they need direction. And so I know that we've got a lot of great leadership in this country that's doing that, but we can do better. Everybody has to also trust. We have to rebuild trust and make sure that families feel that they're getting a straight answer and that they are getting good direction.
Mr. Walker?
I couldn't agree more with Terry. In fact, it's almost identical to what I was thinking in terms of it's very unfortunate, and this relates to the vaccine question as well. It's very unfortunate that there are all of these conflicting messages, and it has resulted in a high degree of reluctance to even take a vaccine. And it's really important to stress appropriate safeguards and appropriate protocols, just as Dr. Davis did, in order to build that trust or rebuild trust in this country. And you can take that example and apply it to the entire area of caring for or addressing the issues of Alzheimer's disease. The issue for us is getting more people, policymakers, appropriators, to truly understand the issue, the challenges. One problem is that most people don't think about this until they have it as a personal experience in their own lives and families. And we don't want that for everyone. We want people to understand long before then about the challenges of long-term care, and particularly Alzheimer's disease and dementia.
Dr. Davis?
You know, there's very little I can add to what my colleagues have said, but I'd make this point. As effective as we have been in advocacy, we have to understand that there's much, much more to do in that line. The epidemic that will be the baby boomers reaching the high risk for Alzheimer's disease age would essentially cost more money to Medicare right now than the entire Medicare budget is currently. We need to address that, and we need to address that with research and science and investing much more money in multiple approaches to prevention and treatment. As much as we think we've done a good job of enhancing that NIA budget, it's still grossly inadequate to the epidemic that we're about to face.
And can you just do a shout out for participation by our communities of color in your research and why it's so important?
Well, Mount Sinai lives on the juxtaposition of the richest and poorest zip codes in America. We provide the same care to everyone. So when we see the disadvantages that happen to our minority populations, it's painful to an extreme. So in our centers, we try to do everything we can to include minorities in all our studies and in all our work, because we know how critical it is to have a largest possible population for anything that we do.
Thank you all for joining us. By the way, Terry, AARP is being celebrated tonight at our gala. So
Nice.
good collaborations. Thank you, Mr. Walker. Thank you so much, Dr. Davis, for joining us. And thank you for the work you do, both in research and on the front lines of our care. I'm now going to turn the program back over to our fearless leader, George Friedenberg.